Hi, everyone. My name is Lucy Schiffman, and I'm the Senior Manager of Community Engagement with the Myotonic Dystrophy Foundation. And I'm so excited to welcome you to our Myotonic Dystrophy in Motion Awareness Month Stump the Doctor webinar. Tonight, we'll have time to learn from experts as well as ask them questions. But first, I want to share a little bit about our work. So the Myotonic Dystrophy Foundation's vision is to envision a world with treatments and a cure for myotonic dystrophy. Our mission is made up of three components, some of which you may be familiar with: community, care, and a cure. We support and connect the myotonic dystrophy community. We provide resources and advocate for care, and we accelerate research towards treatments and a cure. We have a variety of resources and support programs that are available to you from MDF, toolkits and publications, which include resources for care providers, doctors, clinicians, as well as families and those living with DM, which include our exercise guide for people living with myotonic dystrophy, the heart community guide, the DM and the heart community guide, anesthesia guidelines, our MDF toolkit, mental health guidelines, as well as clinical recommendations. We have resources for clinicians and researchers, including opportunities for funding through grants for DM research. We also have support programs. These support groups are led by trained community volunteers. And these programs create a safe space to network, learn, and share about your experiences. Online, you can find our digital academy, where you can view hours and hours of educational and inspiration videos by DM experts on demand. And you can also find our calendar of events, where you can see all of our upcoming support groups, conferences, webinars, and more. Find all of these resources and more at www.myotonic.org. We would love for you to stay in touch with us. In addition to signing up for our webinars and participating here, you can follow us on social media, Instagram and X at Myotonic Strong, and then Facebook and LinkedIn at Myotonic Dystrophy Foundation. And of course, we encourage you to sign up for our monthly dispatch, our emails at www.myotonic.org/sign-up. I do just want to share a little bit about some upcoming events. Like I said, this is a whole month of movement awareness programs, and we have our final programs next Monday on the 28th, which includes a Movement Monday, 30 minutes about flexibility, followed by our final movement and meeting happy hour at 4 p.m. Pacific and 4:30 p.m. Pacific for the happy hour. We also have our Ask the Expert webinars each month for the remainder of the year, including this Friday, July 25th, where we'll have Seeing DM Clearly about ophthalmology and myotonic dystrophy. When you sign up for one of these events, one of these Ask the Expert webinars, you'll be registered for all of the upcoming ones as well. So no need to re-register. Once you're registered, you can attend all of our webinars, as well as watch the past ones on Zoom events. I want to encourage you to keep moving all year and not to miss the opportunity to buy a limited edition Movement Makes Myotonic Dystrophy Emotion Awareness Month t-shirt, as well as a variety of MDF exercise gears. You can find more and start your order at myotonic.org/in-motion. We also want to take a moment to encourage all of you to join the DM Family Registry. Through the registry, we learned that 42% of myotonic dystrophy registry respondents reported having difficulty walking. So patient registries are key to improving diagnosis, care, and quality of life for people living with DM. By joining the registry, you can help inform programs like this, as well as support DM research across the world. I want to take one moment to thank our movement committee, who helped put this event and the whole month together. Our movement committee is made up of experts in the field, as well as amazing DM community members. Of course, we need to thank our amazing Myotonic Dystrophy in Motion Awareness Month sponsors, Avidity Biosciences, for supporting this webinar and the rest of our programmings throughout July. Thank you all for joining us this month. I'm really excited to be welcoming you to our Stump the Doctor. So because this program is a Stump the Doctor, you will all have the opportunity to ask questions live. On your Zoom screen, you should see either on the bottom or the top a Q&A button where you can click to open the Q&A and then type your question in the field. You can send anonymously or share your name with it, and then you click send. Throughout the webinar, we'll have time to learn from our speakers, and then we'll have a Q&A at the end. Go ahead and submit your questions, and I'll help you ask them at the end. So without further ado, I'm very excited to introduce our three speakers. So joining us tonight, we have Dr. Andy Rohrwasser, who is a staff member at MDF, joining us in November 2023 and serves as our Chief Scientific Officer. Andy's domain expertise and passion are rare diseases, genetics and genomics, and newborn screening. We also have a PT joining us. Dr. Donovan Lott is a research professor within the Department of Physical Therapy at the University of Florida. His research interests include investigating skeletal muscle damage, exercise, and the relationship between muscle pathology and function mobility in people with neuromuscular diseases. And lastly, we have Dr. Wheeler, who's an associate professor of medicine in the cardiovascular medicine program at Stanford, as well as the director of Stanford Center for Undiagnosed Diseases, which is a clinical site for of the Undiagnosed Disease Network. He pursues projects and collaborations at the intersection of striated muscles genetics, genomics, therapeutics, and clinical investigations. So without further ado, I will pass it off to Andy, who will be moderating this discussion.
Great. Thank you very much, Lucy, and welcome everyone. It's really a rare occasion that we have experts and expertise in the area of cardiology, so the heart and the circulatory system, as well as experts in the area of the skeletal muscle. So what I thought we'll do today, I've broken this conversation down in three pieces, in three components. We start with the heart and the vascular system, and we look at the normal tissue and what's different in myotonic dystrophy. Then we do the same for the skeletal muscle, asking exactly the same question. In part two, we then ask and look at how do these systems play together in the normal versus the state of myotonic dystrophy. And then we'll conclude with high-level summaries. So let's start with you, Dr. Wheeler. What's the latest research and evidence regarding cardiovascular health in myotonic dystrophy, as well as it relates to exercise?
Yeah, well, first of all, thanks to everybody for putting this together, and thanks for joining. The heart's obviously an important organ. It's one of my favorite organs, although they're all critical. It has, it serves the primary function of pumping blood around the body, but it also responds in response to various stressors, including activity and exercise, public speaking, other things like that, where the sort of normal function is to increase in rate, increase in the vigorousness of contraction, and increase the amount of blood that's going around the body. And so the vasculature is also important to the function of the heart because it helps control where blood is going. It controls the pressure of blood going to various parts of the body. And so particularly with exercise and activity, the muscles that are active get more blood flow. That requires more demand from the heart oftentimes, and other parts of the body, say the stomach or the digestive system, might get less blood flow. And so when we take care of patients with myotonic dystrophy, oftentimes they have gut symptoms, they have heart limitations, they have heart rate limitations, they have muscle limitations, and part of some of the things we do in terms of monitoring is understanding what degree the rate of the heart, the function of the heart, and the function of the vascular system all have on the ability of people to do the things they want to do. And some of the symptoms of sort of activity intolerance can be due to any parts of the system. So I think one of the new things that is not really new, but is increasing awareness that the typical causes of heart disease or heart attacks, what we in the field call myocardial infarctions, and the risk of that is impacted by some of the other parts of myotonic dystrophy that impaired glucose handling or sugar handling can lead to increased risk of artery disease. And so we need to think carefully about how we manage the risk for that as well. And so those are kind of a few of the angles that we think about, and certainly we'll talk more over the hour about some of those impacts.
So you already mentioned insulin resistance and essentially the pre-diabetic state. Can you also comment on cholesterol, the importance of cholesterol monitoring, and then maybe loop back to the impact of exercise on the normal heart versus and circulatory system versus the system affected by myotonic dystrophy?
Yeah, so insulin resistance leads to typically increases in triglycerides, which then can lead to secondarily increases in blood cholesterol. And the treatment of high triglycerides, high cholesterol starts with cholesterol and starts with cholesterol lowering, both in our guidelines and in our practice. We are able to use sort of typical medications for controlling cholesterol in the majority of our myotonic dystrophy patients without causing untoward symptoms. And I think, again, that's something that maybe 15 or 20 years ago, not everybody in the field was considering or was, I would say scared is maybe the wrong word, but concerned about. In terms of exercise, exercise does a few things. It can change the difference between resting heart rate and active heart rate. And so it can kind of make the heart more efficient over when you're not exercising other parts of the day. It slows the progression of heart stiffening, which is a really important component of how the heart is affected in patients with myotonic dystrophy. The heart ages earlier, it gets stiffer earlier. And so exercise can combat that stiffening function, stiffening disease. What exercise doesn't seem to do is change the effects on the conduction system, the electrical system of the heart, the pacemaker system of the heart. Thus far, we don't have a lot of evidence for or against exercise altering the conduction system scarring, which is one of the most common things that we need to manage and treat in myotonic dystrophy. And then from a cholesterol handling perspective, from a artery disease perspective, and whether that's artery disease to the heart or artery disease to the brain, we know that exercise does reduce both cholesterol and non-cholesterol pathways that contribute to artery disease. And so again, all these things, leading to what I generally say as a cardiologist, which is exercise is good for your heart, it's good for your blood vessels, it's good for your brain. And as Donovan will tell us all, it's good for other parts of your body as well.
Wonderful. So that the high level summary at this point, exercise is good in the normal state as well as for patients with myotonic dystrophy. So Dr. Lott, now let's do the same exercise with the skeletal muscle. What's different in health versus myotonic dystrophy? And then same question, right? How are the effects of exercise beneficial and or detrimental?
Sure. Well, and again, I just want to thank Lucy and everybody for having this together here as well. I really appreciate this opportunity. And with myotonic dystrophy, we have different changes that are ongoing within the skeletal muscle itself, starting at what's happening more at the RNA genetic level, moving forward different proteins that can change the muscle tissue to where inside healthy, unaffected muscle, we have these proteins, we have these sliding filaments that contract and produce force. And over time, with the pathological process from myotonic dystrophy, that can be changed and impacted to where some of those muscle fibers start to get replaced with fat and fatty deposition and non-contractile. So the tissue that is there within the muscle becomes less capable of generating force because there's less of these sliding filaments to be able to generate that force. So we know that's ongoing from one piece as far as looking at where things are. The other is keeping in mind with regards to there's a potential for an increased likelihood of muscle damage of what may occur. Now, the good news is we know that fear, which it used to be as of several years ago, of let's not do anything to exacerbate the condition, is something that we can do something that can be beneficial to the muscle in for people with myotonic dystrophy. So we do know that moderate intensity exercise, both from a resistance level or strengthening, as well as from an aerobic or cardiovascular level, can actually have a positive impact on skeletal muscle, as well as the respiratory system, as well as other kinds of parameters that we may think of from a quality of life and psychosocial, impacting positive on things such as anxiety, things such as depression, things such as daytime sleepiness, which is a very important factor that affects a lot of people with myotonic dystrophy. So having these kinds of interventions, and again, one of the things I like about exercise is, there's a lot of other items that are out there to take medications and different things that are there, which can have wonderful impacts. But there's also side effects we have to keep in mind as well. And with exercise, if we're doing an appropriate level of exercise for what we're doing, there aren't negative side effects per se. It can have a multi-systemic impact on skeletal muscle, on psychosocial matters. And as we know with myotonic dystrophy, how it impacts so many other of these multi-systemic systems, that can also have a positive impact for what we're doing. And the research that's been out there, we have some limitations in that it's newer that we're getting some quote unquote good or better research on exercise and myotonic dystrophy. But we're starting to get a better understanding of what are some of these other mechanisms that are ongoing. And what we really need to do is twofold. One, be able to have longer studies beyond what is typically the 6 to 12-week exercise program to be able to see these longer impacts and have a better viewpoint of what's ongoing, because the impact on muscle in unaffected individuals, these positive effects often can have a more rapid impact after 6 months of exercise that may take a little longer for some of the other changes that we'll see in myotonic dystrophy. And the other that ties into that is really looking ahead at what we need to have from a point of view of getting better understanding of specific parameters. So just like when you take a medication, you would need to take a dosage, what is the amount that we're going to take? How often do we take it? And these kinds of parameters in the exercise world, the American College of Sports Medicine, they'll have the FIT principle: frequency, intensity, type of exercise, and time of exercise. And we need to have a better understanding of those. So we're just starting to scratch the surface. And when I say just starting, it's been the last 3 to 5 years that we've really started to look a little bit more specific at parameters and looking a little bit more at some of these, I'm going to say more molecular and cellular based changes that are ongoing. So it's an exciting time that we're able to see some of these benefits across the board of what's ongoing from an exercise standpoint in people with myotonic dystrophy.
So that's wonderful. And I guess the take-home lesson is again the same, right? Safe exercise in the right environment. Again, we have beneficial effects for the skeletal muscle and beyond. So in the next part of the conversation, let's briefly talk about safety and exercise plans and what to do before we start. And again, we want to approach this from the skeletal muscle as well as from the cardiovascular system. And maybe let's this time start with you, Dr. Lott.
Sure. So from a safety aspect, as far as looking ahead and planning for exercise, the first item that I'll put out there, and Dr. Wheeler is a cardiologist and physician, I think will agree, if you're going to be starting a new exercise program, it's important that you're speaking with your physician and medical team. Because while we talk about general principles of exercise that are out there, you as an individual, as somebody with myotonic dystrophy, or your family member with myotonic dystrophy, can have some individual characteristics and some impactful pieces in your individual medical history that are going to be important. So do make sure you're speaking with your physician and healthcare team before starting any new exercise program. The other is to keep in mind as you're getting forward is thinking about what is it that you can do. Um, there's a lot of different parameters. There's different pieces that are out there, but do what you can do is an important piece. The mantra that you'll hear often is start low and go slow. So shouldn't be something looking to sprint. I need to start tomorrow with this exercise program. Dr. Wheeler and Donovan were talking about exercise. I need to just get going really hard and heavy. The key is to starting with something that you can do safely, that you feel good about, and that you then give yourself the time to see how your body responds. Give yourself at least 24 hours to 48 hours to see how your body is responding. As you're doing exercise, this is not something that should exhaust you as you're doing the exercise. That is different than what people may be telling high schoolers as far as doing different kinds of athletic competitions, because that's not the point, that's not the purpose. But you should be doing something at a level that you feel a moderate kind of intensity. So if it's something that's an aerobic or cardiovascular kind of element, they talk about a 0 to 10 scale, a rating of perceived exertion, where 10 is exhausted and 0 is you feel like you're doing nothing. You should be in that 5 to 6 out of 10 range. Or doing a talk test. So as you're doing that exercise, that you should be able to talk, but not be able to sing while doing that exercise. So it's just enough that you can talk and get a few words out, but you can't sing. You're breathing enough for that. And from an exercise resistance standpoint, you think again about that Borg or that rating of perceived exertion. But also, if you're doing some weights and lifting and moving, it should be something that you can get in somewhere between 6 to 12 repetitions. But you shouldn't get to that point where you're going up that I just can't get it, and I'm collapsing down. But when you're finishing, you should be able to say, I could probably get maybe one more. And that's probably a good point to where you're stopping with things. So keeping things in mind that you're working, because you're not striving to become like a professional bodybuilder. That is not the purpose. That's a completely different way of trying to exercise. But you're striving to be able to get therapeutic, beneficial kinds of changes that can occur and take a little longer, but to keep things moving ahead in a way that will impact not just hypertrophy or larger muscle, because that often is not the case of what we see in people with myotonic dystrophy, but still have a lot of benefits with regards to improved balance, improved mobility, improvements in some of these other aspects that have with psychosocial. And we're starting to see other changes with regards to when doing resistance exercise. We're actually seeing changes in what we call the powerhouse of the cell, or the mitochondria, which we think more with aerobic cardiovascular kinds of exercise. But we're seeing that the resistance exercise actually have an impact on those, and that they seem to stem back. And so we're impacting muscle in different manners in people with myotonic dystrophy, that we feel, and when I say we, the clinical scientific community, that we're going to have a better understand how this can work together from an integrated overall exercise type of program.
Cool. Dr. Wheeler, what would you say, safety before we start? What's important? What should we consider?
Yeah, I think the primary component for safety with regard to the cardiovascular system is, are you having symptoms? If you're having symptoms doing usual daily activities, and we don't know where those are coming from, then again, that's something that you need to talk with your physician before you try to do more. We have a general recommendation for everyone with myotonic dystrophy that they have a baseline ECG. And so you should have your electrocardiogram, ideally before starting an exercise training program, but hopefully you've had that already if you carry the diagnosis of myotonic dystrophy. And that's about it, honestly. We do have more concern if people are having frequent falls, and they're unwitnessed, or they come with loss of consciousness. That's a big red flag that we need medical care and further workup. But oftentimes people are having falls or balance issues because they haven't been as active as they can be. And so one of the things from the physical therapy literature is actually exercise training programs improve balance in myotonic dystrophy and reduce falls and reduce, and if people are having falls from a cardiovascular perspective, we always wonder, is that because there's a loss of blood flow to the head? And if we do our typical testing, we don't see any evidence of conduction system or loss of pacing, loss of the intrinsic pacemaker of the heart. And typically is a balance issue, and typically exercise will make that better. That's something that's a relatively small percentage of the myotonic dystrophy population, where that's something that kind of comes up when we first start meeting people, right? People as they're, I think one of the important things, and this is true for any exercise or activity program, is Donovan talked about kind of do what feels comfortable initially. As you get more experienced in that exercise program, symptoms that come up that didn't used to come up is again an opportunity to say, hey, is this, I need to talk to my care team. We need to figure out what this is. As you might imagine, as a cardiologist, people are asking about chest pain, and chest discomfort related to using the upper body to do weightlifting and coming after upper body exercise days, very different than chest pain that's coming on with increase in activity. But again, in the vast majority of people, when we're having these initiating conversations, we're not seeing any red flags, and we're saying, go ahead, let us know if things change.
Great. You're kind of stealing the thunder. Everyone is talking about the respective different organ systems. So in this next part of this conversation, let's talk about how these two systems play together and what can we do from an exercise perspective, right, to improve this working together. And then maybe what we could do, let's talk maybe about exercise plans throughout a patient's disease journey, where you maybe could touch upon the minimally affected patients, that same patient later in life, and then even later in life. What's important? How does exercise change? And what do we need to do again, right, to be to have the best possible and the safest possible outcome?
Yes.
Donovan, do you want to start, or whoever?
Sure. So as far as thinking about what the literature, the studies that have primarily done, really most of those with the exercise myotonic dystrophy have utilized people who are in that minimally to moderately impacted. And so as we look at the literature, and this is where I think this is a great item to address here, because as you're starting off in that area, we do know, again, that moderate intensity, like I was mentioning with regards to aerobic exercise, with regards to resistance exercise, that we have those out there. And there's a great document that I'll just mention now with regards to exercise guidelines for people with myotonic dystrophy that the Myotonic Dystrophy Foundation has. I think Lucy can put a link in the chat at some point so you can look more at some of these. What are some of those recommendations that are there? And those recommendations do fit across the whole board, but the studies really are doing a little bit more of these individuals who have better balance, who can stand and walk and do a lot of items, who can balance themselves while doing weight exercise, because there are 4 areas we should do and concentrate on with exercise. I've mentioned 2, the resistance or strengthening, the aerobic. The other 2 fall under what Dr. Wheeler's mentioned. One of them is balance is an important part, and 4th is flexibility. All of those should be addressed, and realistically, all of those should be addressed across the lifespan. So regardless of where you're at. But what can change, if you're thinking from a balance perspective, is I may be doing some things in standing a little bit more high level. I may be standing I may be closing my eyes, I may be standing on one foot, I may be standing on foam surfaces where I'm safe, I have something to hold on to if I'm losing my balance. But as the disease progresses and I'm having a little bit more difficulties over time and I'm more of that moderate severe, my balance type of activities may be very different. I may do things now more in a seated environment because I can't stand as well. And we can work on seated balance in a chair, looking at different kinds of movements and what's needed from a torso or a trunk balance. And that's an important aspect as well. Or it may be standing where you're holding on to chairs or counters. And so you're always touching, but you're shifting your weight side to side. So that's one way from a balance perspective of how things may change. I'd mentioned about, weights and things that a lot is in the literature from resistance standpoint. With the progression of the disease, it may not be that weights are going to be what you're going to use. You may have some elastic bands that are pulled a little bit to be able to give you some resistance that you can do. Or it may get to the point where it's your body weight of moving your arms and legs. That may be something that is of sufficient where this is at moderate intensity. I can do this up to 6 to 10 to 12 times. And as I do that, that's what I can do before I get to that point where I need to stop because I'm getting to that point where it's that 5 to 6 out of 10 for that perceived exertion. And so those are some changes over time of thinking about what may change from your resistance, from your balance, and even from an aerobic component, where if you're doing something where it's maybe up and doing a lot of fast walking and movements from lightly affected individuals to where that's a little bit more impacted and walking maybe is not as safe to do. There's different kinds of means of cycling and things. And when cycling may be a stationary bike, it may be utilizing an arm cycle. There's different means to get that heart working in a safe fashion that keeps you at a safer position to decrease any risks of falls and other pieces that are there as well. I'll stop and let Dr. Wheeler chime in, but I'm happy to come back to anything there too.
Yeah, I think a lot of time we get questions about what is the kind of heart rate range we're looking for, and again, I think the heart rate range that you might see like at the gym on the device or the high school athlete is going for, those are not the heart rate ranges we're typically looking for. But it is something that is also going to change in many of our myotonic dystrophy patients as their conduction system and their intrinsic pacemaker system changes. And so we tend to prescribe exercise less related to those heart rate targets and more related to perceived exertion. And so there will be people who have myotonic dystrophy who will get to that 5 or 6 out of 10 and be close to their max achievable heart rate. And that's okay, because that's not reflecting that the heart isn't able to do more. It's reflecting that the pacemaker system of the heart isn't able to provide more. But that is an area where then the intersection between our activity care guidelines or guidance and our cardiology care often intersects. And so you may have heard of pacemakers or getting implanted devices to support the conduction system of the heart. And that's one area where both my patients and patients across the country may get some additional exercise benefit from pacing. And I think that's one of the areas where people are often surprised by how limited they felt because they have such limited change in heart rate. And so we do kind of de-emphasize that. But on the other side, in terms of intensity, we do not anticipate that we're trying to push into that 8 to 10 range. Again, and more of the kind of exercise literature for people without skeletal muscle limitations is pushing towards these higher intensity burst type activities. And that's not something that in myotonic dystrophy we think is going to work either now or in the future. And mainly not because of cardiac limitations, but because of limitations related to the skeletal muscle.
So again, both systems are very much interconnected, and both of you essentially said that the progressing through the life cycle, we need to adjust and monitor and to have this sustained effect. So to accommodate sufficient time for attendees to ask questions. When the two of you look at the most important lessons learned in terms of exercise and cardiovascular health versus exercise and skeletal muscle health, and maintenance thereof. What do you think are the three most important things or elements as kind of a summary transitioning into the Q&A period? Maybe I go with you first, Dr. Lott.
So if I'm going to mention three, I think the first and foremost is, and this has been emphasized, moderate intensity exercise is safe. Modern intensity exercise may look different from somebody with a lighter amount of involvement from myotonic dystrophy than more severe form, but moderate intensity exercise is safe is a big thing to keep in mind. The second is that we really do need more research looking at the long-term benefit of exercise, but we do see things that it is safe to do exercise in people with myotonic dystrophy of a moderate intensity, and that there are benefits that are out there. Sometimes I've had people say, why do I exercise? I can't get this big hypertrophy. It's not happening anymore. It's a different focus for where that is, about well-being, about getting more of a systemic involvement, a lot of other pieces that are there. So that's another big. The third one that I haven't mentioned that I think is really important is to do something that you get out and are active and do something that you enjoy. If exercise is a laborious task that you just hate doing, that you dread, it's not going to be something that you will have long-term success with. And so it may be something that is completely different than anything that came out of here as we're talking. It may be, it could be gardening. It could be, something that gets your heart beating, that gets you moving, that's getting contractions of your muscle that you're doing, that you think, this is what I do. You're starting low, you're going slow, you're progressing, you're getting to that point where you're breathing a bit. You're getting to that point where it's a 5 to 6 out of 10 on that rating of perceived exertion, and it's something that you enjoy doing. Make sure that you're taking the time to enjoy what it is so that you can have the benefits long term from that exercise that you're doing.
Dr.
That's a great point for you to jump in and just say, whether or not you exercise tomorrow is not going to impact your cardiovascular health, right? Whether or not you start, tomorrow or next week and continue for the next 3 years, that might impact your cardiovascular health. And so, on a day-to-day basis, it's about, building that routine and investing in the longer term in terms of cardiovascular health. But we want to be cognizant of symptoms and changes in symptoms. I love when my patients are exercising because they're doing their home stress testing, right? If something changes while you're exercising in terms of how you feel versus how you usually feel, that's an early warning system of the heart that maybe we need to do, take a better look. But in the majority of patients, like, they do that, they feel fine. We check in on the heart once a year, and we know that people can live longer and live better. And so those are the things we're looking for. And again, it needs to be something that's sustainable. So it can't be something that you can only do 1 day a week and then you're like in bed the rest of the week because you're so sore, right? And so similarly, from the heart perspective, the heart, it's a, again, compared to other organs, it's a very robust organ. And so it can go through a lot and get you through a lot. But to have the benefit to the cardiovascular system, it does need to be, over a year. So if people are less affected, starting earlier, your heart's going to do better. People are more affected. We want to keep the as much quality of life and quantity of life as we can. So I think my 1, 2, and 3 takeaways are, be in it for the long haul.
Great, thank you. Now let's so there are many more discussion points. We are just beginning to scratch the surface, but maybe Lucy, it's now time. Let's hand it over to address and answer those many questions we received, right? And that are coming in.
Yes, thank you all. Thank you for that very informative discussion and presentation. And I want to remind everyone, you can go ahead and submit questions. On the bottom, there's a Q&A button. You can go ahead and type out your question and submit it live, and we'll do our best to answer as many questions as possible over the next 20 minutes. So one question that we got is, we've been told not to overdo it or to lift to exhaustion because it could do more harm than good. What does that mean? And I know, Dr. Lott, you spoke about this, about doing so that you can still do a little bit more, but can you explain more? The question is, do muscles not grow back for people with DM, or do they grow back in a different way? Or does this simply relate to the level of soreness you may have after a workout?
Excellent question, first of all. And there's some information that we don't know as far as how the muscle responds. Does it grow back? What we're starting to see with a few studies is that we can have some hypertrophy or some increase in muscle size with some of the studies that have been done. It does also appear that it's going to be dependent on how much of that muscle tissue is present when you start that exercise. Because as I've mentioned earlier, with that fatty infiltration, if you don't have as much muscle tissue, you have less of a therapeutic window, less of an opportunity for that tissue to actually respond in that kind of a change. And so it's important that we do things in a safe manner. And notice everything that I've talked about from an intensity standpoint, and Dr. Wheeler's mentioned, it's a moderate intensity, which again is very different if you're going to go to the gym and you're going to say, I'm here not with myotonic dystrophy, I'm here as an unaffected individual, and I just want to get the best workout ever. I want to be buff. They're going to talk to you about a lot of high intensity eccentric loading. If they're talking about a rate and perceived exertion, it's not going to be in 5 to 6. It's going to be in that 9 to 10 to push you through it as much as you can. Doing that high loading not only can be uncomfortable, but it can lead to more susceptible muscle damage that can be there. And so we need to be careful with not doing too extreme with high intensities kinds of loading with exercise. That is not going to be something that'll be beneficial. That is not something that's going to result in positive changes for somebody with myotonic dystrophy from the evidence and information that we have. And as well as what we have is we've looked at a lot of individuals just anecdotally as well.
Awesome. Thank you. I think this.
Lucy, can we go next to maybe there's a whole group of questions with regards to when a patient would know when he or she would need a pacemaker or a
That is exactly what I was
defibrillator.
going to ask next.
Right. And but let's combine that also with the question
how to exercise with a pacemaker, or how it may.
exactly how
You
it
read
would
my mind,
impact.
Andy.
Okay, so let's group those together, right?
Yes, thank
Okay,
you.
great.
So the next question, like I said, there's a lot of you are on the same wavelength. So we have one question about, does having a pacemaker impact your ability to exercise or do cardio, or lift or raise your heart rate? And then a follow-up question is, how do you know when you might need to get a defibrillator or a pacemaker? So I think I'll pass that to Dr. Wheeler.
Yeah, so I think the second question is definitely a harder and more nuanced discussion, because having a pacemaker or defibrillator implanted is a discussion that needs to happen with your care provider, your care team. There's questions about longevity and quality of life, and it's a procedure and things like that. And so my recommendation is to make sure that you're on the same kind of wavelength with your cardiologist and team, and have a good discussion about pros and cons. Oftentimes people who have been followed sequentially get to a borderline, and there's a few people that, whether I or someone else in the cardiology community see them, it's very clear that a pacemaker is going to be beneficial, the first time they have their cardiac testing. And so, but there are guidelines, and there's a guideline document for our electrophysiology colleagues who implant those devices that we've all agreed upon as kind of the guidelines that should be followed. As I mentioned or alluded to, many patients with who go ahead and have a pacemaker or defibrillator implanted will have them implanted, one, so they can provide pacing, and second, so they can respond to activity. And so oftentimes when people are starting to have issues with their intrinsic conduction system, what they're born with, their heart rate doesn't go up much when they're active. And that can lead to feeling of shortness of breath or tiredness or fatigue or lightheadedness. And oftentimes a pacemaker can help with those symptoms. And so again, I've had many patients over the years they have their pacemaker implanted and suddenly, and with the function of a pacemaker, they are able to do more activity, feeling less windiness or less lightheadedness, or less, and have more ability to be active. Sometimes we need to adjust the pacemaker to allow the level of activity that someone is able to do to be sensed by the device. And there's ways to optimize that as well. But aside from right after the device is implanted, kind of in the measured in days, most people have no limitations to activity with their pacemaker in place. And so whether it's upper body or lower body exercise, our patients are able to do anything that Donovan and his team can come up with to help them.
Awesome. Thank you. So we have a couple questions regarding other muscle groups, specifically in the GI tract, and neck and shoulders. I know those are very different muscle groups, but is there anything that folks with DM can do to maintain or improve strengths in these other non-large skeletal muscles, and how those might work during PT, or if that's not part of a PT program?
So what I heard was, and I'm going to reverse the order. You said shoulders, neck, and GI system. Is that correct?
Yes.
So I'm going to go in that order because I think that's a little easier to answer from a PT perspective as well. With the shoulders, you're looking at both muscles that are around the shoulders, like think of the outer arm where there's primarily the deltoid. You also have the biceps, the triceps, the crossor, the latissimus dorsi, and then you have smaller muscles that are inside, that are a little closer. The rotator cuff. We hear there's 4 different muscles that help seed in, and so it's important if you're going to be looking at that shoulder that the smaller muscles also are worked to a way to be able to provide proper movement of the arm along with the larger muscles on the outside. So I think it's going to be important to go ahead and do items that you're looking at. Where is the weakness that's ongoing, but don't neglect those small muscles. And so there are pieces that you can do that are safe. If you're at home, where you can do isometric kinds of exercises. These are exercises with no movement. We're standing against a wall where you're coming up, and I'm going to stand up a little bit here. And there's a wall as you're pushing up in this fashion against the wall. You're pushing and you're holding that and then relaxing. You're getting exercise for the deltoid that does this main, but you're also getting a little bit of loading through there for the smaller muscles. Same thing with going ahead and getting up to a wall and pushing against that wall. So wall push-ups. Think of a push-up where you're on the ground, but instead you're against a wall. You can do that kind of work where it's now you're working muscles that are around the joint to give a lot of good integrity around that joint, because that's often what I've seen with people with myotonic dystrophy. A lot of it is you need to have what we call proximal, or closer to the core stabilization at a big joint like the shoulder in order to be able to move it up above. So I would work on that inside out as you're going ahead with things. I think it's a big piece that sometimes people don't think about as they start going through, and is an important piece when you're thinking of the shoulder itself. As far as the neck flexors clinically, I tend to tell people that's the first muscle group we start seeing weakness in. For people with almost any kind of muscular dystrophy that I've worked with. And so a lot of it comes back again. I'm going to use that isometric exercise again, where utilizing exercise where it's doing something. Again, if your arms are strong enough to do so, you can use your arms. You can use a wall with a towel where you're going up and in essence, you're pushing your head in this direction against the wall or the arm. So it's a no movement exercise where you're contracting and pushing and holding that while still breathing for about 5 seconds to get some contractions. And I would do that in all 4 directions: forward, side, to the right, the left, and back. So getting some good stabilization. It's not something at this stage that I'm going to say, get a big piece on your head and do a lot of big weight lifts and things of this nature. That's beyond, and that could be something that people may need at some point, but typically it's more for getting that stabilization, and in particular the deep neck flexors that are having a problem. So stabilization around that to give your ability to hold that head up a little better with those kinds of isometrics. And again, breathe while you're doing isometrics. The last muscle group I heard as the GI system. So here we're looking at, we've been talking about skeletal muscle that we've heard a lot, that term, and cardiac muscle. GI system is a third type of muscle system that's the smooth muscle system. And that's a great question because we know the gastrointestinal system, the smooth muscle, is impacted in people with myotonic dystrophy. I have not run across anything from an exercise standpoint specific for myotonic dystrophy that's looked at the GI system. We do know in people of any kinds, if we want to be able to improve GI motility or gastrointestinal movement, that having a more active kind of a lifestyle can be very beneficial. And that active lifestyle, I'm not referring to that means you need to run marathons. I'm referring to make sure that you're moving and that you're walking. And if you're unable to walk safely, that you're doing something again with what we talked about from a aerobic cardiovascular standpoint. Keeping yourself moving does, again, exercise impacts the whole system. It's a multisystemic, which can have that impact on the GI system. Now, I say that again from what we know of general exercise, but I don't know that specifically for people with myotonic dystrophy for something other than applying these same kinds of principles, which I think would be a great area for further investigation because of how much GI motility is involved in people with myotonic dystrophy.
Thank you. Another question I think that will be aimed at you, Dr. Lott, is whether there's an increased frequency and severity of repetitive strain injuries in folks with DM that are also involved in sports or just in general.
Very good question. I have not seen any literature that's looked at the incidence rate of repetitive strain kinds of injuries in people with myotonic dystrophy participating in sport. That said, my suspicion is that you would have a potentially increased risk, but I don't think it'd be a huge, great increase. I think you'd have some because of where that muscle tissue is at from a possibility of not being able to be loaded as much. But I think it comes back down to, and I think Dr. Wheeler talked about this, doing what's within your limitations and what is safe. So as you're going ahead, I'm at the age now, and I do not have myotonic dystrophy, but I'm at the age now where I can't do what I could do 20 years ago. And as I talk to patients with myotonic dystrophy, there can be some frustration. I can't do what I could do 5 years ago. And we have changes in our bodies, and it's important that we're able to see what can we do, staying active and doing what we can, but trying to be sure that we're doing it in a safe format. So again, anecdotally, there may be a slightly increased risk, but I have not seen anything from an incidence standpoint of any statistical piece. But I think doing what is safe for you, doing exercise at that moderate intensity, doing things that you're enjoying, but keeping in mind where you're at. And if you are having anything that's painful, Dr. Wheeler talked about it, talking to your healthcare provider. Exercise and activity you're doing should not cause muscle soreness that's lasting more than 24 hours. You should not be focusing on things that are causing big soreness, that are causing exhaustion, but doing things that will be able to have a stimulus to your muscle and your system that is that moderate intensity, doing activities that you can enjoy for the long term.
Thank you. I have a question here for Dr. Wheeler. We know that many people with DM may experience bradycardia or a slower heart rate than average. And how does that influence your ability to monitor cardiovascular exercise or cardio exercise? And at what point should you worry about having a low heart rate before you begin your exercise?
Yeah, that's a great question, and I think that is a question we get a lot in clinical care of myotonic dystrophy patients. Bradycardia or slow heart rate is something that can be benign or potentially dangerous, and so that's where EKG and if there are symptoms, a rhythm monitor can come in. But many patients, their set rate, their heart rate, intrinsic, resting heart rate is a bit lower, but they feel fine. And in most cases, there's nothing we need to do about that. But when we're thinking about exercise, then if oftentimes their set rate, resting rate is lower and their peak heart rate is lower. So that, like, again, the exercise equipment might say, oh, take 220 minus your age and then do 85% of that. Well, for many of our myotonic dystrophy patients, that's like 30 or 40 beats per minute above what their heart can do at maximum, right? And so we do see that the range of heart rates kind of comes down as people's conduction system progresses. And again, there's unpublished and published data that suggests that that sort of change in the range of your intrinsic heart rate is part of the conduction system aging faster than it normally it should be in the effect of myotonic dystrophy. And so that's something that we watch. Again, if it's causing symptoms, we think about pacemakers, but we don't know, again, another thing, we don't have enough information to know if longer term activity and exercise training may slow that progression, may preserve that sort of heart rate variability. And so that is something that, again, work that the foundation is doing, work that some of the research groups are doing, may uncover. And again, it's people volunteering for provide this information and teams working together to figure out that aspect of thing. But if you're going about your daily life, the year between when you see your cardiologist and the next time you see them, and you have no symptoms, and somebody says, "Oh, you have bradycardia, that's dangerous," you need to think carefully about whether that's true or not.
Thank you. We have a couple clarifying questions about how to start, and I know both Dr. Lott and Dr. Wheeler mentioned starting slow and testing it, but I'm wondering if you can touch more on do you want to start with low weight, low reps, low weight, high reps, high weight, low reps, and what might be an intermediary there, as well as if you are doing resistance or weight training exercises, how does doing pyramid lifting or changing your lifting style impact your exercise versus just sticking with the same sets?
So I can go ahead and talk, and Dr. Wheel, if you have anything to add, please do so. I'm going to reverse the order of that, with regards to pyramid and different kinds of means of doing things. There are a lot of different ways, and I teach an exercise science class to the physical therapy students. And so we talk about it not specific to myotonic dystrophy and neuromuscular disease, but general principles. And there are some specific principles of going about that with different goals in mind. So realistically, the work that's been done in people who are who don't have a severe impact of myotonic dystrophy that have demonstrated good improvements tend to stick more in that 6 to 8 repetitions by a great group that's out of Canada that's done a lot of good resistance work, and or people that'll look a little bit more of that 8 to 12. And that's more fitting than that moderate repetition. Low reps is kind of 5 and below, and higher reps tends to be where it's above 12, 15 and above. And so really sticking to that moderate repetition, and whether you're starting or moving forward, that is what we have from the literature. Those are the best numbers for parameters as far as repetitions, and somewhere between 1 to 3 sets. So I would recommend getting that resistance that you can do in that number of repetitions, starting with 1 set, doing that, giving yourself 24 to 48 hours to see how you're doing, because this should be something you do 2 times a week is great, no more than 3. You want to make sure you give yourself at least 1 day of rest in between each time you're doing that. So 2 times a week is great and sufficient. But giving yourself that chance to, I wouldn't go ahead and worry about increasing the repetitions in that range. I would look at, once you get to that point of, what? I can get to 10 repetitions and I could probably do 5 more. Well, that's probably where you need to go and say, let's go ahead and maybe rest and now try another set and see what you do. If you can do 8 again, that's probably good. Now you've added that extra set. And over time, look to add that increased weight. So still staying in that 5 to 6 for the rating of perceived exertion, still staying where you get up to that repetition range of what we talked about from that 6 to 12, and getting to that point where, I can't do more than maybe 1 more. That's where you want to be saying, okay, this is good. I'm getting that point. And so as you get to that weight where I can do 6, 7, and that's about what I can do, you may see as you do that, that's going to increase to 8, 9, 10. Once you get to that 11-ish kind of range, think about that little increase in weight. Think about that adding a set up to 3 sets. And that's a way that I think from a progression from some of myotonic dystrophy would be more consistent with what we've seen in the literature than having a change with a different kinds of loading paradigm, pyramid or other, as well as trying to be able to look at changing the repetitions from a low, again, less than 5 or less, or a high 12 to 15 or greater kind of a range.
Thank you. I think we're going to just answer one last question for tonight, and it's something that comes up often in DM communities regarding heart health. And I know, Dr. Wheeler, you mentioned earlier how exercise pertains to cholesterol and managing that, but we do have folks asking about taking statins and how that may impact, and if that's safe for them with DM2.
Yeah, so for both DM1 and DM2, we do use statins, and the most recent consensus cardiology statement for DM does it also agree with the practice, and we use them differently, just like Donovan's been talking about, starting low and going slow. In most cases, we do start them at lower doses than we otherwise would, and increase them, and making sure that we're not worsening, causing new symptoms, worsening any muscle symptoms. And we've had really good success with lowering cholesterol without bringing on new symptoms. And in many cases, we also have a risk-benefit discussion with patients, because we know that in some cases, we're using them for primary prevention. In other cases, we're using them for secondary prevention. And the risk-benefit ratios do change. There are also other cholesterol-lowering medications out there, many of which have less potential direct effect, but a few of the newer statin medications have less risk of skeletal muscle directed effect. And so, I see patients regularly who've been told by one or another cardiologist or neurologist that they can't, and but the community, again, we have now years of experience, if not decades, of patients taking statins for cholesterol lowering, for protecting their brains and their hearts and the rest of the vasculature. And it is ultimately, the recommendations are that it is generally safe. So I think but it has to go in the context of all of your other medical care as well. So.
Awesome. Thank you so much. And thank you everyone for joining us. I would like all of you to join me in giving one last big thank you to Doctors Rohrwasser, Lott, and Wheeler for having this conversation, talking about the ways heart health and exercise work, and ways that everyone living with DM can find ways to exercise safely and go about their days and celebrate Myotonic Dystrophy in Motion Awareness Month and keep exercising for the rest of the year as well.